Can we start?
Yes, I think let's begin.
Okay.
So, good evening, everybody. Uh, Today is our second session on electrophysiology, and as you are already aware, amongst the four lectures, our first lecture is on alpha coma, another of the EEG one, and it will be delivered by Dr. Ajit Cherian, who is a professor at Sri Chitra Institute. So I request everybody to take advantage of this nice educational session, and I request Dr. Cherian to start his lecture after him. You can start.
Yeah, thank you.
Yeah.
At the outset, I would like to thank Dr. Puchari for the kind invitation and kind words. So my topic is on alpha coma. These are basically to be learned at the electrophysiology lab or in the ICU. But then one should have a basic background idea about what you're going to see in the EEG graph. So I'll be taking you through these subheadings. First, we'll look at the definition and where it is identified and what has been the incidence of alpha coma, the pathophysiology behind it. And there is something currently which has happened in the last year after the SARS COVID infection. And what is the prognostic significance of alpha coma and what is this new term or entity called as transitional alpha. So let's first go to the definition. Alpha coma is a term used when a predominant alpha activity frequency is noted in a comatose patient, which is continuous but neither posterior dominant or reactive. So there are three terms. So it is an alpha frequency activity, but it's not posterior dominant. It could be anterior dominant or it could be seen in most of the channels equally, and it is not reactive. So these are the three entities that define alpha coma, and the state of the patient is comatose. So you can have a GCS of something like 3/15 or 4/50, something like that. So where is it found? That's the second area. Three main groups of patients have been observed to manifest alpha coma. So three subgroup of individuals. One is diffuse bihemispheric brain insult, usually seen after some cardiopulmonary arrest. So after a cardiac arrest or a respiratory arrest, after resuscitation, you can see this kind of alpha coma. Second is in those with localized brain lesions at or just caudal to the phonomesencephalic junction. That is at the junction between the pons and the midbrain. So that is the level at which you can have a lesion. So what kind of lesion? It could be anything. It could be a vascular insult like a brainstem stroke, or it could be a severe demyelinating insult like as it's seen in ADAM or even in a NM aquaporin related myelitis sort of with brainstem involvement. So anything can cause this kind of involvement. Or it could be due to a bihemispheric brain insult due to various toxic or metabolic problems. Usually toxin associated. It could be some harming entities which may cause a very severe bihemispheric brain insult. So three subtypes. One is after a cardiopulmonary arrest. It could be cardiac arrest or respiratory arrest. Second is after a brainstem insult, usually at the level of the pons and the midbrain. It could be any kind of lesion. Third is toxic or metabolic lesion. So these are the three subgroups. What has been the incidence of alpha coma in critical care? So it was first described in the year 1953. And if you analyze all the data since 1953, approximately 335 thereabout cases have been reported. So average global incidence is just over 7 cases per year. But this is basically the literature data. The actual data may be much more than this. Now, third point is that how do you differentiate this alpha coma from a normal alpha? So one should be very good in the electrophysiology to differentiate one from the other. So let's look at what is a normal alpha. So normal alpha rhythm is of lower frequency. In the alpha range itself, it's somewhere in the 8.5 to 9 or 9.5. And it's higher amplitude than the alpha activity during coma. And it displays a spindling, suggesting a voltage modulation. What do you mean by spindling? Because there is a variability of the frequency of alpha. And this can be seen even otherwise, like even normally, even if you don't give any mental health meeting or ask the patient to close the eyes itself, you can see some alpha spindling. So that shows the voltage modulation. And it's prominent over the posterior head region, and you can look for the reactivity by asking the patient to close and open the eyes, or by asking the patient to do some mental arithmetic. So how does this differ from the alpha coma, which is seen in a comatose patient? So this is an alpha activity which is towards the beta spectrum. So it is towards the higher frequency, maybe 12, 12.5 sort of, and it's lower in amplitude. Always remember, the higher the frequency, always lower the amplitude. So delta range activity will always have a higher amplitude than an alpha or a beta. So this is towards the higher alpha range, so 12, 12.5 and lower amplitude range. And this alpha activity is sustained, and it shows very little voltage modulation. That means the normal spindling that you see in a background alpha will be absent in alpha coma. And the third point is that this is seen more anteriorly over in widespread over all the channels, and it's unreactive. So what exactly is the pathophysiology? The real brain generator of alpha frequency in coma is not clear. So many authors believe that this represents a de novo abnormal pattern, but certain animal studies have shown that after an hypoxic brain insult, alpha-like activity first appears with maximum amplitude in the amygdala. So amygdala could be a generator because this activity could be blocked by bilateral ablation of the amygdala, but not by destruction of the cerebral hemisphere, suggesting that from the amygdala it is generated and manifested over either cerebral hemispheres. So this is just one based on some animal studies. Now, if you look at pharmacological depression of the brainstem of reticular formation, which is seen in many metabolic or some drug-induced or toxin-induced comas, what happens is that this reticular depression by these agents plays an important role in the pathogenesis of drug-induced alpha coma. So it means that in certain other conditions, this metabolic or toxin or drugs can play an important role in suppressing or depressing the brainstem reticular activity. And this may be the culprit or the cause of alpha coma seen in structural brain disease, where you have a lesion at the pontomesencephalic junction. So there are two pathophysiologies which have been postulated. One, amygdala being the generator of alpha coma. Second is a suppression of the brainstem reticular activation. So these are the two pathophysiologies related to alpha coma. Now, how often do you see? It is a transient and rather a short-lived EEG phenomenon. That is one thing which you need to understand. So it may be present only for a few hours or a couple of days at the most, and then it shifts. It keeps shifting. So that is the most important. It is not a final end event sort of. So alpha coma is a very transient, transitional EEG phenomenon. So in one patient, in one study, it has shown that it has completely disappeared in his second EEG, which was done a few days, 1 week later. So that shows that it is a very transient event. So in the study by Young, he has reported that alpha coma changed to an alternate pattern after 6 days on an average. So the mean duration of alpha coma persistence was only 6 days. It had shifted to some other rhythm thereafter. In another case reported, alpha coma occurred 2 hours after the onset of post-myocardial infarction, hypoxic encephalopathy, and it disappeared 12 hours. So in this report, it lasted only for 10 hours. So in other ways, what it means is that it's a very, very transient phenomenon. It may last for a few hours or a couple of days or maximum or average of 6 days. So I'll just touch upon this work that we had done. We had a patient who had a very fulminant hepatic failure, and he was admitted in our ICU. And because he was a patient who had a background history of epilepsy, we wanted to rule out non-convulsive status. So we had connected the electrodes, and we had a continuous monitoring of his electrical activity from the day of admission in the ICU till he succumbed to his illness. So what we found was that his EEG evolved from an alpha coma to a spindle coma. So this kind of transition was actually seen. So on day 1, what it had shown was a frontally dominant alpha frequency without reactivity. That was what we had seen on the initial day 1 and day 2 of ICU stay. So from the third day, what happened is that this shifted to a spindle coma, where you see sleep spindles, vertex sharp waves, and K complex, but he is unarousable, unlike in a stage 2 sleep. So this was this alpha coma that was seen on the day 2. So it's a frontally dominant monotonous kind of alpha frequency activity without any reactivity. And what happened was that on day 3, it's just shifted. Like if you are asked this to interpret this EEG, you'll say it is just like a stage 2 sleep, because you are seeing spindling, you're seeing some slow wave activity, and you're seeing what's the vertex waves, and it looks like a normal sleep architecture. But the difference is that this is in a comatose patient and it's present throughout his 24-hour record. So that was the change that we saw. So again, suggesting that this alpha coma is rather a shiftable or a transient entity. So one might see more patients with alpha pattern if we perform more frequent recordings at regular time intervals in the ICU for encephalopathy patients. So it may be prudent, like if you want to look really whether it's evolving, you may have to go for a continuous monitoring in all the patients in the ICU. Now, what new has come in this topic? So alpha coma EEG pattern may be a marker of SARS-CoV related encephalopathy. So this is a paper which has come in clinical neurophysiology last year. Basically, the earlier prints are actually available. So alpha coma may indicate a predilection for the COVID virus for brainstem reticular system, because this was seen in individuals with an encephalopathy, and they had a very delayed kind of alpha coma presentation. That was the uniqueness of this entity. So this is the graph which they had shown. If you look at this one, you can see that this is it's a alpha. It's more like an infantile montage that they have, because a very restricted montage that they have given. It's not the full 1020 system that they have applied here. But you can see that there is an alpha activity which you see here, and monotonous, non-reactive. These are basically the respiration-induced artifacts that we have mentioned here. So if you take out these delta, it is more or less like a monotonous alpha that you see here. Now, late occurrence of alpha coma pattern in SARS-CoV has been reported in comparison to evidence from literature. So they have noticed this alpha coma pattern after 14 to 27 days of ICU admission, and it turned around the peak severity of COVID-19. So it's around after the second week that they have noticed this alpha coma pattern. But in all the other cardiac arrest, respiratory arrest, or drug-induced coma, alpha coma pattern is usually seen in the first few days, like from day 1 to day 5 of the insult. That is what. So if you have a very delayed alpha coma pattern in an unknown encephalopathy patient in the ICU, it may suggest a SARS-CoV infection. And the second point is that may suggest a predilection of this virus for the brainstem reticular activity. And 2 more points is that, can you see alpha in locked-in state? Yes, you can see. But this is actually a normal alpha, because patients with alpha coma have to be distinguished from those with locked-in state. Because in the locked-in state, the patient is actually arousable. Patient is not comatose. So these patients usually have an alpha rhythm with a normal topography and normal reactivity in locked-in syndrome, and they are actually conscious, though they may appear to be in coma because they are mutant quadriplegic. So this is something which one needs to be careful about, because you should not misinterpret this as alpha coma, because they are actually, their GCS is actually much better than those in patients with comatose patients. So in these cases, a reactive alpha rhythm suggests that the patient may be awake, and it is actually a locked-in syndrome rather than a comatose state. Now, does this alpha suggest have any prognostic significance? There is one paper in JNNB which came in 1983. Alpha coma resolved in the first 24 hours following hypoxia may have a better prognosis than alpha coma detected after the first day. So a resolving alpha coma may be better. That is what they had suggested in that paper. So, but there is another paper which says that most of the entities had been having a poor outcome. So any patient with a brainstem lesion, or any patient who is having an alpha coma after a cardiac or respiratory arrest, usually tend to have a poor outcome. But except in patients with drug overdose. But in patients with drug overdose have survived without sequelae, provided they did not have much of respiratory arrest. So that was the only difference that they noticed. So in this paper, what they noticed was that brainstem lesions as well as cardiac and respiratory arrest patients have a poor outcome for alpha. Unlike in patients with drug overdose, they had an improvement of the alpha coma, and they had improvement and a better survival despite the presence of alpha coma. So this is the last entity. There's a term known as transitional alpha. So an alpha pattern not present in the initial EEG after hypoxia, but appears late in the later recording, usually indicates a poorer prognosis when it is followed by several hours later by electrocerebral sinus. And this shifting alpha is known as the transition alpha. So initially it may show a diffuse suppression or a delta grade 2, a suppression grade 2 pattern, and then briefly a transition alpha may come, but this is often followed by a electrocerebral silence kind of EEG. So this is intermediate alpha is known as the transition alpha, and this also usually has a poor outcome. So in this brief last 10-15 minutes, what we have noticed is that gone through is the definition, where to identify alpha coma, what is the incidence, pathophysiology, how to differentiate from a normal alpha, what is the importance of alpha coma in SARS-CoV infection, what is the prognostic significance, as well as transition alpha. Now I have got certain MCQs. If Dr. Puchari agrees to it, I can show the MCQs now itself.
Ajit, actually, our system is that we are doing the quiz later on after 2 or 3 sessions.
Okay, fine. Then I'll stop here.
Yes. So we generally do at the end of 8-10 lectures.
Okay.
Thank you. Yes, yes. So very good. So as everybody has noticed, how the lecture was organized into subtopics and how all the important points, differences between alpha comas and the prognostic value, everything was highlighted. I hope all the PGs absorb these points and make use of them. Thank you very much, Dr. Cherian, for this very lucid and very the point talk. Thank you. Let's begin our second lecture. Another important issue, neurogenic versus myogenic pattern. And we are going to learn from Dr. Divya, who is also an assistant professor at Sri Chitra Institute. And I hand over the session to Dr. Divya. Divya, please. Divya, you are muted.
Yeah.
No, that's fine. Great.
Good evening. At the outset, let me thank Dr. Pujari for this opportunity. So without taking much time, I'll go to the topic proper. So it's always a pressure to be pressure and a pleasure to be presenting after Dr. Ajit, who is an excellent speaker. So I'll just go to my topic proper. So we are going to deal with neurogenic and myopathic patterns, the clinical and electrophysiological differences. So I'll be dealing with the basic physiology, the analysis of the MUAPs, normal morphology of a MUAP, the patterns in various pathology, some of the additional clues which will help us to diagnose the pathology in a clinical setting, and then we'll just have a quick recap of them. So as in any neurological case, whenever we go for the EMG studies, they only serve as an extension of clinical examination. And a well-directed neurological examination should always be performed before any electrodiagnostic study. So we have to start with the basic physiology, because without learning the basic physiology, we cannot understand the direct morphology as well as the pathology of an MUAP. So as we know, the motor unit consists of a single motor neuron and all the muscle fiber which it innervates. And the ratio of these muscle fiber to the motor neurons, usually it ranges between different types of muscles. And if we see the extrinsic eye muscles, it's like 3:1, which is very fine. Or in large limb muscles, it is about several thousands for one single motor neuron. Now, when a motor neuron depolarizes, a nerve action potential is generated, and this results in all the muscle fibers of the motor unit being activated and depolarized simultaneously. So each word of that is important. So when a motor neuron is depolarized, a nerve potential is generated, and all the muscle fibers of the motor unit are being activated simultaneously. So that generates this morphology of a MUAP. Now, when we analyze each MUAP, it has to be assessed for the morphology, which includes the duration, amplitude, and phases, which we will be dealing with in the next few slides, the stability of a motor unit action potential, as well as the firing characteristics. And this will help us to determine whether a disorder is primarily neuropathic or myopathic, to determine the time course of the disease, whether it is acute or chronic, and also it helps us to grade the severity of the lesion. Now, the sum of the potentials of the individual muscle fibers innervated by a single anterior horn cell is recorded by the electrode. Now, primarily, this includes the motor units which are about 0.5 millimeter near the needle tip. And a normal MUAP consists of 2 to 4 phases. Phases means the number of times this potential crosses the baseline. So usual MUAP consists of 2 to 4 phases, and the duration of it is 5 to 15 milliseconds, and it has a variable amplitude depending on the needle position as well as the normal state or the pathology. Now, this is how we usually record an MUAP. This is recorded in a setting where the settings are 200 microvolt per division. That is the amplitude characteristic, and the sweep speed of 10 milliseconds. That means between these two dots, you have 10 milliseconds. So this one page usually has about 200 milliseconds. That is 20 into 10, 200 milliseconds. So this is how it is recorded. And what are the things we need to analyze in the MUAP? One is the duration. Duration means that is the time the line leaves the baseline from the beginning of this to the end of the action potential. That is the duration. The number of phases, as I said, number of times the line crosses the baseline plus 1. That is how you calculate the phase. The amplitude, which is calculated from peak to peak. That is from the negative peak to the positive peak is the amplitude. The turns. Turns means this is not, the phases are when it crosses the baseline. Now, without crossing the baseline, when the cursor crosses only without crossing the baseline, that is called the turns. And the rate of rise of the fast component. This rate of rise is called the rise time. You have to have a very good rise time to be analyzing an MUAP correctly. Essentially, this denotes the proximity of the motor unit to the needle. So it has to be less than 0.5 or 0.3 millisecond for us to analyze the MUAP correctly. And each MUAP, the various characteristics depends on the age, the muscle study, the location of the needle, and the activation, as well as the type of the needle that is used. This is in a normal state of the patient. Now, the set is from the initial takeoff to point to the return to the baseline. So this is how we calculate the baseline and the duration, and that is normally 5 to 15 milliseconds. And the amplitude, as we said, is from peak to peak. The phases is related to the interval between the arrival time of the action potential. So it indicates essentially a desynchronization or a dropout of the muscle fibers if there is an increase in the phases in the action potential. And we also look for early reinnervation. So if there is plenty of turns and phases in the muscle unit action potential, it suggests that there is an early reinnervation. And turns and serration, as I said, the change in direction of the potentials that do not cross the baseline are called the turns. And this indicates a less synchronous firing of the muscle fiber of a motor unit like polyphasia. So this is like you have plenty of turns here. And when it crosses the baseline, you call them as phases of the potential. So another important characteristic is the firing pattern. So when a patient is asked to contract a single muscle unit, then what we see when you ask the patient to contract, a single muscle unit begins to fire semi-rhythmically. That is, there is a rhythm that is generated, and the muscle fires at a frequency of 4 to 5 hertz. I will show you with the help of a picture next. Now, to increase the muscle force further, there are two ways that the muscle can act. That is, either by the motor units can increase their firing rate, which is up to 50 hertz, additional units can fire. And this able to increase the firing rate is called activation. So normally the ratio of firing frequency to the number of different MUAPs firing is approximately 5:1. That is, I'll just show you here. So here, as we said, it's a 10 millisecond sweep speed. So there are 20 divisions here. So it's around 200 milliseconds. So this means there is an MUAP, there is a motor unit that is firing here. So you can see there is only one single motor unit firing here. And so this is firing at a frequency of 5 hertz because it is 1 in 200 millisecond. So there will be 5 units in 1 second. So the frequency is 5 hertz. Now, as the muscle is activated further, we can see that more MUAPs are coming into the picture. That means the firing frequency has increased. Now, when there is a further addition of the firing frequency, it has become more than that. It has become around 10 hertz. You can see different types of MUAPs coming here. Same thing coming here. So in a 200 millisecond, this is further increased. You can see this will be at a frequency of around 15 hertz. And again, another MUAP here. So when that is called a recruitment. So when you have a additional activation, more and more muscle units are activated. So this is a normal phenomenon. So there can be changes in any of these parameters which will help us to find where is the pathology. So initiation of the firing of additional motor units is called activation. And as activation increases, there is a recruitment of further fibers. And it is assessed by the recruitment frequency, which is the frequency of firing of a unit when the next unit is recruited. And normally it is 5:1. Now, what do you mean by interference pattern? That is, during a maximal contraction, the multiple MUAPs will be firing and they will merge to give this kind of pattern when there is a obliteration of the individual shapes and baseline. So this is a full recruitment or a complete interference pattern that will be normally seen with complete activation. Now, what happens when there is a pathology? So let us say there is an acute denervation. Now, when there is an acute denervation, up to 3 weeks, actually nothing happens to the normal MUAP morphology. It remains normal, but the only thing that happens, because it takes time for the motor units to get undergo changes of the Wallerian degeneration. So up to 3 weeks, the MUAP will be normal, and there will be a reduced recruitment because the motor units cannot be recruited to gain the necessary force. When there is a chronic denervation, on the other hand, the renervation occurs. So let us see, this is a normal motor unit, and you can see the fibers which are coming from that. Now, what happens is when there is a renervation, when there is an injury, you can see that some of the motor units will be, the motor neurons will be lost. So the adjacent motor neurons start attaching to the nearby fibers. So per unit, there is an increase in the number of muscle fibers. And hence what happens is when you activate the muscle, there are plenty of, and it is asynchronous. So what happens is there is plenty of phases in the action potential that is generated. The duration henceforth increases, and the amplitude also increases as the duration of the injury increases. So the number of muscle fibers per motor unit increases, and on the top of it, they are asynchronous. So this in chronic denervation gives us a chronic denervation and renervation, which results in polyphasic potentials, which are of increased duration. So this is a classic neuropathic potential. So to shorten, a MUAP becomes a prolonged in duration. The amplitude increases because the number of muscle fibers per motor neuron increases, and there is a polyphasia as it becomes asynchronous. And also, though these renervation occurs, the muscle may not be able to generate the complete force, and there is a decreased recruitment as motor units are reduced and the existing ones are large. Now, what happens in a myopathy? Now, in a myopathy, there is a muscle fiber dropout. The anterior horn cell of the motor neuron is intact. However, the muscle fibers are dropping out. So the number of functioning muscle fibers in a single motor unit decreases. So what happens is when there is an action potential that is generated, you have few muscle fibers, because of which there is a short duration. The amplitude also reduces because the number of muscle fibers are less, and they are also less synchronous. So sometimes you may see a polyphasia. So what is characteristic is the short duration and the small amplitude as compared to a normal MUAP. So this is a myopathic potential because of the muscle fiber which have dropped out. Now, in myopathy, there is an actual number of functioning motor units remains normal. That is, the motor neurons remain normal. So more MUAPs will fire for a certain level of force as exerted by a single MUAP is low. That means when you try to activate a muscle, what happens is the number of fibers are less, so more muscle fibers come into action, and this gives rise to an early recruitment. So here we can see that is the type of recruitment. So early recruitment is a characteristic feature of myopathy. So this is a complete interference. There is no individual MUAP which can be identified here separately. You see multiple types of MUAPs which are joined together in this recruitment pattern. So there are more than 400 turns. So this is a maximum volitional activity. On the other hand, this is a neurogenic pattern where it is incomplete. Incomplete because you are not seeing a pattern as good as this. So you can identify the individual motor units here. So this is an incomplete or a reduced pattern, and this is seen in a neurogenic potential. And this lower down in C, what you see is an early recruitment. That is, there is almost a complete recruitment. You can see multiple types of motor units that are there. But compared to the normal, you can see that the amplitude is quite low. The duration cannot be assessed here. However, what you can see, this has to be assessed on the bedside when you are doing the procedure, that this pattern is obtained even with an incomplete or a less minimal contraction of the muscle. We can see this kind of pattern, and this is called the early recruitment, which is very characteristic and one of the earliest changes that we see in a myopathy. So this is a recruitment pattern. It's a maximum volitional activity. We can see that you can identify the muscle fibers individually. So this is an incomplete and reduced recruitment pattern, and this is usually a characteristic of a neurogenic pathology. So recruitment is more easily evaluated at moderate levels of contraction than during maximum contraction, and a maximum contraction is more painful and needs to be avoided. So what are the MUAP patterns and the pathophysiology? That's what we discussed in the last 2-3 slides. I'll just put it together. So when you have an acute neuropathic and axonal pathology, what you see is a normal duration, normal amplitude, normal phases, and a normal activation. So that is in the acute phase. That is what you see on the EMG. And the recruitment will be reduced because the power is reduced. And in a chronic neuropathic potential, what you see is a duration which is increased, the amplitude is increased, the phases are increased, and the activation is normal while the recruitment is reduced. And in neuropathic demyelinating pathology, what we see is a normal duration, amplitude, phases, activation, and recruitment. In a demyelinating lesion, everything will be normal in the early phases unless there is a secondary axonopathy. And in a myopathy, what happens is the duration is reduced, the amplitude is reduced, the phases may be increased, and the recruitment is characteristically early. So what are the additional clues one can gain from the spontaneous activity? In neurogenic lesions, you can have in addition fibrillation potentials, positive sharp waves, and fasciculations depending upon the pathology. I think the next lecture will be covering that. And also in myopathy, additionally, sometimes fibrillation potentials and positive sharp waves may be seen as an inflammatory myopathies where you can see an irritative process, which is suggestive of an irritative myopathy. And in myotonic dystrophies and some of the muscular dystrophies, we can in addition also see myotonia that is present. So to summarize, EMG studies are always an extension of the clinical examination. A well-directed neurological examination should always be performed before the electrodiagnostic studies, and each study must be individualized. And when in doubt, think about re-examining the patient and the technical factors. Thank you.
Thank you, Dr. Divya. As you can see, everybody can see how in a very simple way through all the basic, basic pathophysiology she has taught us and how to basically gain understanding as to why a particular morphology appears and why the wave has the characteristics what it has. Once this foundation is created, then you will not have any problems, both as a clinician as well as answering questions. Thank you very much, Dr. Devya. That was very, very lucid and very basic lecture. Thank you. We'll move on to another very important area, which is the spontaneous discharges. And we will learn it from Dr. Swati Shah, who who is an ex-fellow from Boston and who is at present practicing neurologist in Ahmedabad. So I request her to begin her lecture. Dr. Swati.
Thank you, Dr. Pujari, and thank you for the nice invitation. And I will be talking to you guys about the spontaneous activity that we'll see on the needle EMG. So the learning objectives of this talk are that we're going to learn today about what are the different types of normal and abnormal spontaneous activities that we see in the muscle at rest. We will look at the sites from where they are generated, their physiology and the differential diagnosis, and how they help us in diagnosing various neuromuscular pathologies. Sorry. Okay, so as we all know, electromyography refers to the recording of the action potentials of the muscle, firing singly or in group when they are placed near a needle electrode. They help us with the diagnosis of various neuromuscular disorders. And typically we use two kinds of electrodes in the needle EMG. One is the surface and the other one is the needle. Most commonly the needle electrode is used, and there are different kinds of needle electrodes available. The concentric, monopolar, single fiber, and the macro. Depending on the needs of the test, we pick the needle electrode that we are using for the study. So any needle examination starts with the assessment of the insertional activity. So when the needle is inserted into the muscle, and is quickly moved around through the muscle fibers depolarize in a brief burst for which lasts for several hundred milliseconds, usually less than 300 milliseconds in duration. So you can see here, this is a normal insertional activity, which appears as a cluster of positive or negative spikes. And it's a very high frequency spikes that you will see here. And any activity, spontaneous insertional activity that lasts beyond 300 milliseconds, so you can see here, is considered as an increased insertional activity, which can be seen in various neurologic, neuropathic, or the myopathic disorders. So they don't suggest one versus the others. So it could be in the muscle as well as the nerve that you can see an increased insertional activity. So a muscle actually is electrically silent at rest. So when you insert a needle beyond the end plate, you will not hear any noise. So if you hear a noise when you insert a needle into the muscle, that is considered an abnormal spontaneous activity. So let's first, to analyze any kind of spontaneous activity, you can either do it by recognizing the pattern, which you will gain with the experience, or by analyzing the waveform. So when you begin doing the EMGs, you need to initially learn to analyze the waveforms by looking at it morphology. So that means the amplitude, the duration, as we heard, and the turns that it takes. And most important also in spontaneous activity is the initial deflection. So that gives us a lot of times the clue whether this is a fibrillation potential versus the end plate spike. So that is very important. The other characteristics about the morphology is it also helps us identify the source of the spontaneous activity. So based on this, it can be the spontaneous activity may arise from the motor neuron or the axon. So these are the various kinds of spontaneous activity that arise from there. It could be a terminal axon, the terminal tweak of the axon, that is the end plate spike. It could be the neuromuscular junction, that is the end plate noise. It could be the muscle fiber itself. You will have fibrillation potential, positive sharp waves, and the myotonic discharges. Or it could be multiple muscle fibers that are linked together. There we have the complex repetitive discharge. You also need to analyze the spontaneous activity in terms of its stability and the firing characteristics. So most of the times, most of the spontaneous activities are very stable in their morphology. If they change, if the morphology changes, then you need to look at whether it's a waxing or waning character, or it's just a waning character, or it changes abruptly. And similarly for the firing characteristics, you need to look at the firing rate, whether the potential is firing very slowly or is it fast. You also need to look at the firing pattern. So whether it's a regular or the irregular firing pattern that we are looking at. So let's start with the normal spontaneous activity. So in the end plate region, that's the only region that you will find a normal spontaneous activity in a muscle. the spontaneous miniature potentials occur randomly. They happen because of the release of the acetylcholine from the presynaptic nerve terminal at the neuromuscular junction. These miniature end plate potentials are usually appear as monophasic negative waves, okay, and they are low in amplitude, typically less than 100 microvolt, and short in duration, usually 1 to 3 milliseconds in durations. They fire, because each of them is firing at a different time irregularly. So it is very difficult sometimes to discern the individual potential, and it appears more like an irregular baseline. So this is called the end plate noise, and it has a typical C-cell sound on the needle EMG. So similar to end plate noise, the other activity that you can find at the end plate junction is the end plate spikes. So in the end plate region, we can sometimes record the action potential of some of the muscle fibers, which appear as brief spikes. I'm sorry, it's actually, I'm trying to move it. Which appear as brief spikes, as we saw in the previous picture. And they are very rapid and irregular pattern. And the important thing to note about the spikes is that they are biphasic and they have an initial negative deflection, which helps us distinguish them from fibrillation potential, as we'll look later on. Sorry. And they have a sputtering in the sputtering of fat on the frying pan, as the oil sputters on the frying pan, that kind of a noise. And they're very irregular. And the key feature that helps us differentiate them from fibrillation potential is this irregular firing pattern, as well as the initial negative deflection. Just remember those two things about the end plate spikes. So now let us switch gears and move on to the abnormal spontaneous activity. This was so far the normal spontaneous activity in the muscle. And the most common of the abnormal spontaneous activity that you will encounter in the muscle is the fibrillation potentials and the positive sharp waves, which occur with denervation. The reason we see these potentials is because the muscle fiber, which has been denervated, becomes very sensitive to the free acetylcholine released spontaneously from the adjacent nerve fibers. And these fibers then get depolarized and repolarized spontaneously. And each single depolarization is electrically detected as a single fiber action potential. So this is the generator for the fibrillation potential and the positive sharp waves. So let's now look at the fibrillation potential. As you can see in the figure below, fibrillation potentials, as we heard, are generated by the muscle fiber. So they have the morphology of a single muscle fiber action potential. They appear as a brief spike, and they have an initial positive deflection followed by a negative wave, and sometimes again a positive deflection. So they are typically triphasic in morphology. They are short duration, 1 to 5 milliseconds. So here you can see it is a 10 millisecond, and they're low in amplitude, typically 20 to 200 microvolt. Their firing pattern is quite regular, and they typically occur at a frequency of 0.5 to 10 hertz, but occasionally they can be very fast and go up to 30 hertz. They appear as a high-pitched, like raindrops like dropping on a tin roof. So that is the kind of sound that you will hear with the fibrillation potentials. As we have already heard, it takes about 2 to 3 weeks before you will notice any denervation potential in the muscles after the nerve injury. They can occur in both the chronic nerve disorders as well as the muscle myopathies. And as the muscle gets re-innervated, both the fibrillation potentials and the positive sharp waves, they decrease in number and eventually disappear. But after a nerve lesion, sometimes they can persist for years in the muscles. So the second thing that you would see is the positive sharp waves, which has the same significance as the fibrillation potentials. They also signify denervation. So they have a very sharp positive deflection initially. So if you look, so they have a positive deflection initially, followed by a slow negative phase, that is lot more prolonged as compared to the initial positive deflection. There's also small in amplitude, 10 to 100 microvolt. Occasionally, they can be really large, like 3 millivolt in amplitude. The duration is small, 10 to 30 milliseconds. They have a regular filing pattern like the fibrillation potentials, but they appear, because they are prolonged, so they are much longer in duration, 10 to 30 milliseconds. They appear as dull tick-tock sound like of a clock on the EMG. So both the fibrillation potentials and the positive sharp waves are markers of active denervation, and they're associated with various neurogenic disorders like mononeuropathies, peripheral neuropathies, radiculopathies, or in various muscle disorders, especially in inflammatory myopathies. And rarely in very severe neuromuscular junction disorders, you can also see denervation potentials, especially in botulism. So next, let's move on to the complex repetitive discharges. So complex repetitive discharge is also results from the depolarization of a single muscle fiber, followed by the effective conduction of the depolarization to the neighboring denervated muscle fibers. The depolarization then travels in the circulus route, and the pacemaker fiber is reactivated again. So this leads to a recurrent discharge that is developed. The morphology of the complex repetitive discharge, as you can see here, is that of individual muscle fibers that fire consecutively, so one after the other, and they are time linked to each other. So the morphology stays stable from one discharge to the other. They are very high frequency, so 20 to 150 hertz, and the waveform, it starts and stops very abruptly. They have like a machinery sound that you will hear on the EMG. And the characteristic about these discharge is that they persist with neuromuscular junction blockade, and they have a typically very low jitter on the needle EMG, because the depolarization spreads from one muscle fiber to the other without using a synapse. So that's why there is a low jitter on the needle, on the single fiber EMG. That is different from other myopathies and neuropathy, where you will find usually a typically high jitter. And they are seen in any long-standing neurological or neuropathic or the myopathic disorder. All you need is that the denervated fibers should lie adjacent to one another. So it takes a long-standing lesion only would show a complex repetitive discharge, because that's the only time you will see that the denervated fibers are lying adjacent to each other when there is a grouped atrophy. So next, let's move on to the other spontaneous discharge that you see sometimes is the myotonic discharge. It is also a spontaneous discharge of the muscle fiber, like fibrillation potential and the positive sharp wave. So if you look at the discharge at the bottom, it has the morphology of the fibrillation potential or the positive sharp wave. So they look like them, but they can be differentiated from them by its characteristic waxing and waning character, both in terms of the amplitude and the frequency. If you look here, the time interval between the two potential here versus the here, so the frequency is changing, and also the amplitude of the potential is changing. So this is the characteristic waxing and waning character of the myotonic discharges. They are also high frequency, fire at 20 to 150 hertz, and they have a characteristic dive bomber sound on the needle EMG. Myotonic discharges, as we all know, are characteristically seen in myotonic dystrophy, myotonia congenita or paramyotonia congenita. However, one of the biggest mistakes that sometimes electromyographers may make is thinking of myotonic discharges as acute denervation. I recently had a patient with myotonic dystrophy who has been labeled as motor neuron disease for the last 3 years. So once you have recognized their waxing and waning characters, you will never miss them for acute denervation. Next, now let's switch gears and move on to the abnormal spontaneous activity. So let's start with the generated from the neurons. So these were all from the muscle fiber origin. Now we are looking at the ones arising from the motor neuron. So the first and the foremost is the fasciculation. Fasciculation is a single spontaneous involuntary discharge of a individual motor unit as opposed to the muscle fiber action potential. So on EMG, the fasciculations will appear as a morphology will be that of a single motor unit discharge, and sometimes they can be very complex and large if they are actually arising from a re-innervated motor unit. They are usually heard as an irregular dull pop on the EMG. Sometimes you have to just leave the needle in the muscle and wait for a few minutes before you will hear a fasciculation potential. Otherwise, you may actually miss them. They can be detected visually on the skin. As we all fear about fasciculations with the motor neuron disease, but they can be seen in various other neurological disorders like radiculopathies, polyneuropathies, entrapment neuropathies. And sometimes they can be just benign fasciculations. Benign ones we usually will not be associated with the muscle atrophy and the weakness. So that helps us differentiate them from the pathological fasciculations. So next are the myochemic discharges. As we all recognize myokymia as a continuous involuntary rippling movement of muscles under the skin, the origin of myochemic discharges is considered to be spontaneous depolarization or effective transmission along the demyelinated nerve segments. Electrically, if you look, myochemic discharges are rhythmic and they are grouped spontaneous discharges. So this is a group spontaneous discharge of the same motor unit firing. So this is the same motor unit. This is the enlargement of this group, and you can see it's the same motor unit that is firing at 40 to 60 hertz. The burst then reoccurs every few seconds, and the motor units within the burst are very variable. So the number of motor units within a burst may change from one burst to the other. And they produce a characteristic marching sound on the needle EMG. To recognize the myochemic discharges, it's usually better to increase the sweep speed so that you don't miss the marching sound of the myochemic discharges. The clinical significance of myochemic discharges is like if you see the myochemic discharge, you are limiting your differential diagnosis to a limited number of pathologies, especially in limb myokymia. If you see myokymia, then you're sure it's more likely a radiation plexopathy, especially in patients with cancer who have received radiation in the past, as opposed to the recurrence of the cancer. The other differential point is the pain. Usually radiation plexopathy is painless, whereas the recurrence of cancer patient would have complained of significant pain. The other thing, you can sometimes have myokymia in the facial muscles. They are typically associated with brainstem lesions, usually like multiple sclerosis or pontine glioma. Next, let's move on to the cramp. Cramp, as we all know, is a painful involuntary contraction of muscle that usually happens when the muscle is in its shortened position and it's contracting. So on EMG, you will identify cramp as several motor unit action potentials that are firing repetitively and sometimes irregularly at a very high frequency, 40 to 75 hertz. So you can see this is a motor unit firing very rapidly. The firing pattern appears like the interference pattern, and sometimes they're firing so fast and that it is very difficult to discern the individual motor units. They are believed to arise from the peripheral portion of the motor unit. The significance of cramp is they are clinically indistinguishable from the contracture that you clearly see in the metabolic muscle disorders. However, a contracture is electrically silent, whereas the cramp is painful and has a lot of motor units firing very fast. Next is the neuromyotonic discharges that we see. So neuromyotonic discharges are also very high in frequency. They actually have the highest frequency of any abnormal spontaneous activity, 150 to 250 hertz. They appear as repetitive discharges of a single motor unit. So you can see here single motor unit discharging repetitively. But if you look at a long sweep speed, you can find that they have a typical decrementing character. So the amplitude progressively goes down. As it is called a waning pattern of the firing pattern. and they have a characteristic pinging sound on the EMG. The neuromyotonic discharges are most commonly seen in the syndrome of acquired myotonia, that is the Isaac's syndrome. But these discharges can also be seen in very long-standing neurological disorders like post-polio or adult spinal muscular atrophy. These discharges are believed to be originated from peripheral motor axon, and so they persist even during the sleep and also after the spinal and the general anesthesia. The last one in the abnormal spontaneous activity is the tremor, which is actually an involuntary activation of motor units from the central nervous system. However, on the needle EMG, the tremor is recognized as a synchronous burst of motor unit action potential that are separated by relative silence. So you can look here. So this is a burst of motor unit action potential followed by a relative silence. The multiple motor units fire simultaneously. So it is very difficult to discriminate the individual motor units in this complex. And so this appears more like an increased polyphagia. And usually you will see the tremor clinically also when you see it on the electromyography. But sometimes when the tremor is present at rest, it may be mistaken for the myokymia discharge. The needle electromyography helps to differentiate two. So in the myokymia discharge, it is the same motor unit that is firing in the burst, whereas in the tremor, there are many different motor units that are firing. So you and other thing is that the amplitude of the motor unit varies in the tremor, whereas in the myokymia discharge, the amplitude of the motor unit is relatively stable. So this helps us differentiate the myokymia discharge from the tremor. I think that's all I have. Thank you.
Thank you, Dr. Shah. You've covered so much in such a short span of time. Very nice, thoroughly, and in a very simple way. I think it is very useful for the PGs to understand so many of these spontaneous discharge. Thank you very much.
Thank you.
Now let's thank you. Now let's move on to the last lecture today. A slightly, not so well-read topic, which is blink reflex. It will be covered by Dr. Sapna Sridharan, who is also an associate professor at Sri Chitra. I request her to teach us on this.
Can you see my slides? Hello?
Yes, we are able to see your slides and hear you well.
Okay. Yeah. So, thank you, Dr. Pujari. And after 3 excellent talks on electrophysiology, this will be very brief. I will be talking about blink reflex and its applications in neurology. So my schema presentation would be a brief overview of blink reflex, the technique, the relevant anatomy and physiology, abnormalities and its interpretation, and correlation with imaging with a few applied aspects. So blink reflex, as we know, is an eyelid closure in response to stimulus, which can be of different types. Like it can be a tactile stimulus like corneal stimulation, or it can be an auditory stimuli like a loud sound or a flash of light. In humans and primates, the closing of eyelid is bilateral, while in other animals, especially lower animals like insects, mostly those with eyes set laterally, the closure is frequently unilateral. So in clinical practice, a blink reflex is characteristically provoked by light corneal stimulation or eyelash touching on the cornea, or a glabellar tapping, or any nociceptive or acoustic or a photic stimuli. So going to the background, British physician Overend first elicited the blink reflex by tapping one side of the forehead. It was Kugelberg who analyzed the blink reflex electromyographically first by electrically stimulating the supraorbital nerve. Blink responses from the inferior portion of both orbicularis oculi muscle may be recorded simultaneously by surface or needle electrodes. Usually we use surface electrode and a record from the lower eyelid. So going to the technique, as students of neurology, we are all aware of how the blink reflex is performed in the electrophysiology lab, but this is just a recap. We know that stimulation of the trigeminal nerve or its branch elicits reflex contraction of orbicularis oculi. In contrast to the direct response that provides a measure of the distal nerve hyperexcitability, the blink reflex reflects the integrity of afferent and efferent pathways, including the proximal segment of facial nerve. So how it is done? In the lab, subject is made to lie supine on a bed in a warm room with eyes open or gently closed. For surface stimulation, the cathode is placed over the supraorbital foramen and the anode is placed 2 cm rostrally. The electrical stimuli applied will evoke 2 responses, which I will be describing subsequently, which are best recorded with 2 pairs of recording electrodes. So this is a picture of how we elicit blink reflex, which is taken from a textbook of electrophysiology. So the stimulating electrode is placed over the supraorbital foramen, and the recording electrodes, the G1 electrode or the active electrode is placed over the inferior portion of orbicularis oculi near the inner canthus, and the reference electrode is placed 2 cm laterally, and there is a ground electrode which is kept below the chin. The rotation of anode around cathode helps to establish the optimal position of the stimulating electrode to minimize the shock artifact. So electrical shock of 0.1 millisecond duration of optimal intensity, 5 to 10 milliampere, will elicit a nearly stable R1 response with repeated trials. In 5 to 10% healthy subjects, single shocks of appropriate intensity may not elicit a stable R1 with the stimulation on either side. In these cases, we can ask the subject to mildly contract the orbicularis oculi to facilitate the response. A higher shock intensity may only cause patient discomfort without any satisfactory result. And paired stimulus is usually applied with an interstimulus interval of 3 to 5 milliseconds to get an acceptable response. So to understand the components of blink reflex, we have to familiarize with the pathway. So this is a diagrammatic representation of the blink reflex pathway, which I have taken from an article on neurophysiology. We know that with direct corneal stimulation or stimulation of the supraorbital nerve, the afferent stimuli passes to the midpoints, where it stimulates the trigeminal motor nucleus. And from there is 2 pathways emerge. One is the R1 pathway, which directly goes to the facial nucleus and then passes through the facial nerve. And there is another pathway called the R2 pathway, which via the trigeminal, chief sensory nucleus of trigeminal, descends down to the medulla, and then it supplies bilateral facial nuclei. So to understand it easily, this is a cartoon depicting the same. The stimulation, electrical or tactile stimulation of the trigeminal will, the afferent fibers are going to the trigeminal nucleus, and there is a, this is the direct pathway or the R1 pathway, where from the trigeminal there is a afferent, there is a connection to the facial nucleus, and the facial nerve will elicit a blink response. And via the chief sensory nucleus of trigeminal, which descends down into the medulla, there is a supply to the bilateral facial nucleus, and this elicits the second response or the R2 response. So when you stimulate one side, that is right side, there is an ipsilateral R1 response, and there's a bilateral R2 response. So R1 response relates to an oligosynaptic pontine reflex, whereas R2 is related to a more complex route, including many interneurons in the pons and lateral medulla. R1 serves as a more reliable measure of the nerve conduction along the cranial nerve and the reflex pathway, with only one or two interneurons between the trigeminal input and the responding facial motor neurons. Whereas analysis of the ipsilateral and the contralateral R2 components helps to localize any lesion to the afferent or the efferent reflex arc. So as I mentioned earlier, the blink response can be due to a direct trigeminal nerve stimulation by a tap, or it can be due to indirect stimulation from a distance, like a loud sound or a median nerve electrical stimulation. So the difference between these two responses is that when you apply a trigeminal shock response, then you get an R1 and an R2 response. Whereas if it is a loud sound or a distal sensory stimulation, only the R2 response is obtained. Blink reflex is a powerful tool to measure the excitability of the trigeminofacial reflex arc, and through that the physiology correlates of certain functions which are integrated in or mediated by the brainstem. So what is the normal response when you perform a blink reflex? Imagine these are the very basic cartoon-like depiction of what happens when you do a blink reflex. If you stimulate ipsilateral supraorbital nerve with a recording from the bilateral orbicularis oculi. In normal side, for example, if you're stimulating the right side, you get a right R1 response and a right and left R2 response. And these are the normative data which I have taken from a Journal of Electrophysiology. So imagine what happens with a unilateral trigeminal lesion. So imagine that there is a right trigeminal neuropathy. So there is an affected side or the right side. The R1 response can get delayed or it may be even absent. The ipsilateral R2 response also will get delayed and or it may be absent, and the same will happen with contralateral R2 response also. Whereas from the unaffected side or the left side, if you stimulate the left trigeminal nerve, the ipsilateral R1 as well as ipsilateral and contralateral R2 will be normal. Now see what happens with a unilateral facial nerve lesion. So here the afferent pathway is normal, but the efferent pathway is damaged. So in the affected side or the right, if there is a right facial neuropathy, the affected side, the ipsilateral R1 as well as R2 will get delayed. Whereas since the afferent or trigeminal is normal, the contralateral R2, that is a contralateral R2 response will be normal. Whereas when you stimulate the normal side, the ipsilateral R1 as well as the R2 response will be normal, whereas contralateral R2 response, because the facial nerve is affected, will be either delayed or it can be absent. Now imagine there is a unilateral mid-pontine lesion. In the affected side stimulation, like if it's a right-sided pontine lesion, the R1 response can be either absent or it may be delayed. The R2 response, since R2 response, even though it traverses through pons, the main factor which determined is the medulla. So they can produce an intact ipsilateral and a contralateral R2 response. Whereas in the unaffected side stimulation, there can be a normal R1 and bilateral R2 response. Now see what happens in a medullary lesion. Here, the interneurons to the ipsilateral facial nucleus is affected. So if you do affected side stimulation, the R1 response will be normal because R1 pathway does not involve medulla. Whereas the ipsilateral R2 will be prolonged. And the contralateral R2 can be normal or there can be delay also if the medullary lesion is very severe. In unilateral side stimulation, in the unaffected side stimulation, the ipsilateral R1 and R2 response will be normal, whereas the contralateral side R2 response will be absent. In demyelinating neuropathy, all the potentials get delayed. So if there is a GBS or other demyelinating neuropathy affecting bilateral facial nerve, the response, all the responses, the R1 and R2 responses bilaterally will get delayed. Now, what happens in supranuclear pathology? If you search in literature, you can find that there is a lot of applications for blink reflex in supranuclear diseases, especially a lot of reports on extrapyramidal diseases. In hemispheric lesions, there are reports of R1 response getting delayed, and sometimes there may be a delayed consensual R2 response. In extrapyramidal diseases like Parkinson's disease, there is no effect on short latency potentials like R1 response. However, there is a lack of habituation and also increased excitability of interneurons of the brainstem, leading to shortening of R2 response. Then other disorders of eyelid like blepharospasm, apraxia of eyelid opening, it is said that there is no effect on the reflex arc. So with the advent of high resolution MRI, where individual nuclei and structures of brainstem can be clearly seen, what is the relevance of blink reflex in the current scenario? So the several authors have looked into this aspect as well. And this is one of the early studies which was published in AJNR in 1999. This was by the same Danish group who have done maximum studies on blink reflex. So they have found that with a 1.5 Tesla MRI, with imaging done on patients with trigeminal neuropathies, they found that the imaging, the accuracy of EMG in predicting MR abnormalities were the order of sensitivity of around 100%, specificity of 81%, with a negative predictive value of around 100%. So this means that the still EMG, like blink reflex, has got a very high sensitivity and a high negative predictive value in predicting pathology. So in scenarios where access to MRI is limited, and we have an easily accessible tool like a blink reflex, still blink reflex can be performed as a screening tool before more advanced imaging are advised for. So summarizing, blink reflex is the electromyographic equivalent of corneal reflex. It has an early R1 response which is oligosynaptic and late R2 response which is polysynaptic. It tests the integrity of a large reflex arc, including the trigeminal sensory nerve, the motor nucleus, spinal sensory nucleus of trigeminal and facial nucleus and nerves. It is easy to test, has a good sensitivity and specificity in detecting lesions and reflex arc with reported imaging correlation also. And these are my references. These are slightly old articles, but the figures and the tables are taken from these articles only. Thank you.
Excellent. So very nice, very concise but precise lecture. Thank you. So thank you very much, all of you. We had a very useful session on 4 very important aspects of electrophysiology. I thank all my speakers. Thank you. Thank you. Good night.
Good night.
Thank you, Ajit. Thank you, Swati. Good night.
Thank you, sir.
Thank you. Thank you, Manasi.